imagine trying to overhaul the engine of a massive commercial airliner, but you're currently cruising at 30,000 feet. And just as you unbolt the main turbine, you find out the entire air traffic control system on the ground has just gone completely offline.
Oh, man. That is a terrifying scenario.
Right. You can't land. You can't just coast along. You have to literally finish the redesign midair while navigating completely blind.
Yeah. And honestly, that is exactly the level of systemic flux we are seeing in the American healthcare landscape when you look at the year 2026. Traditional corporate preservation mode.
Yeah.
Just hunkering down and waiting out the storm. It simply is not a viable option anymore.
No, it's really not. And welcome to today's deep dive. Today, we are opening up a stack of incredibly revealing sources to understand how you actually survive that kind of turbulence. We have executive reports, strategy playbooks, and a really candid interview with CEO Sam Hazen.
It's a fantastic stack of materials, yeah.
It is. And our mission for you today, listening, is to decode exactly how HCA Healthcare, which is the nation's largest private health system, is navigating this chaotic collision. It's a collision of radical new healthcare legislation and, frankly, the absolute explosion of artificial intelligence.
Right.
And instead of playing defense, they are relying on a strategy called self-disruption.
Which is fascinating because it fundamentally challenges the standard narrative in these legacy industries.
Yeah.
Usually, massive incumbents just wait for an external startup to disrupt them and then they try to buy that startup. But HCA is attempting to force that disruption entirely from the inside.
Okay, let's unpack this. Because to understand why they are disrupting themselves, we really have to look at the external pressure that's forcing their hand.
Definitely.
And the catalyst here is H.R. 1, the One Big Beautiful Bill Act of 2025, or the OBBBA. Looking through the financial projections of this bill and the source material, it reads like a total paradox.
It really does.
It injects a historic amount of money into certain sectors while simultaneously just pulling the floor out from under traditional insurance markets.
Yeah, it creates this starkly bifurcated reality. So the positive side of the ledger, if you will, is the Rural Health Transformation Program, or the RHT.
Right.
The OBBBA authorizes this massive $50 billion capital infusion running from fiscal year 2026 all the way through 2030. And it relies on a very specific 50-50 split.
Okay, break that down for us.
Sure. So half of that $50 billion is just a fixed baseline, guaranteeing every single state $100 million annually. The remaining half is merit-based. It's distributed by the Centers for Medicare and Medicaid Services based strictly on rural population density and hospital vulnerability.
And when you look at the state-by-state windfalls for that merit half, the scale of that capital is staggering. Texas is looking at an estimated $281.3 million annually for initiatives like chronic disease management and AI telehealth hubs.
Wow.
Yeah, and Alabama is positioned for around $200 million for maternal health and EMS treat-in-place initiatives.
It is a phenomenal amount of targeted funding.
Right.
And this is but that is only one half of the legislative equation. The other half involves some major coverage contractions.
Right. And actually, before we get into these specific numbers, we need to make something explicitly clear to you, the listener. We are impartially reporting the projections and financial models contained in our source material.
Exactly.
We are not taking any political sides here, nor are we endorsing the viewpoints of this legislation. Our goal today is simply to convey the strategic realities and the economic forecasts that healthcare systems are having to model in response to the OBBBA.
Yeah, it's strictly about the numbers and the strategy. And those models, they paint a pretty severe picture for traditional coverage. The OBBBA enforces a rigorous 6-month review process for Medicaid redeterminations, and that's paired with new community engagement requirements.
Which is a big shift.
A very big shift. And on top of that, the law removes the tax liability caps on advanced premium tax credits, or APTCs.
Meaning lower-income enrollees basically lose the protections that previously limited how much they had to repay if their income estimates were inaccurate.
Precisely. And when analysts model those two factors together, the projections show up to 15 million Americans losing their traditional coverage.
15 million. That is just a staggering number.
It is. Health systems are subsequently preparing for a 15 to 20% decline in health insurance exchange, or HIX, volumes. For a system the size of HCA Healthcare, where HIX enrollees represent 10% of their total revenue,
yeah,
those lost volumes translate into a projected $600 million to $900 million financial headwind for 2026 alone.
A $900 million headwind. I mean, that is a massive hole in the hull of the ship. You cannot just absorb a $900 million loss through minor budget cuts or freezing hiring. So how does a massive enterprise actually avoid taking on water there?
Well, this is where Sam Hazen's philosophy of self-disruption really takes over. For the past decade or so, the prevailing assumption was always that some Silicon Valley tech giant would eventually crack the code and, fix healthcare.
Right, like Amazon or Google just swooping in.
Exactly. But Hazen argues that healthcare contains far too much regulatory compliance, clinical nuance, and literal life-or-death friction for outsiders to penetrate effectively. The disruption, he says, has to be an inside job. You have to own your own internal inefficiencies.
And the way HCA attempts to do this, looking at the playbooks, is by weaponizing their massive scale. I mean, they see nearly 10 million emergency room patients a year.
10 million. Just think about that.
Yeah, and instead of letting every hospital operate as an independent island with its own unique processes, corporate functional teams enforce highly standardized, best practice operating procedures across all 180-plus hospitals.
And the metrics they achieve through that rigid standardization are truly remarkable. HCA maintains an average emergency room wait time of just 11 minutes.
Wait, 11 minutes?
11 minutes across 10 million annual visits? That kind of efficiency is engineered. It is definitely not accidental.
I do have to push back on the mechanics of that, though. I mean, HCA has roughly 315,000 employees. Usually when a company reaches that size, scale brings crippling bureaucracy, not agility,
Oh, absolutely.
So how does an organization with hundreds of thousands of people actually pivot fast enough to disrupt itself? How is that physically possible?
It really comes down to a specific leadership competency that Hazen calls the pace of play. It essentially dictates the required speed at which leadership teams must recognize emerging clinical or financial situations and then pivot the organization.
Okay.
And to maintain this, Hazen blocks exactly 10 hours every single week on his calendar, strictly for study, business analysis, and what he calls walking around.
10 hours a week just for study and observation for the CEO.
Yep, every single week.
But, I mean, how does the CEO reading reports in a corporate office make a triage nurse in a Texas ER any faster? What is the actual mechanism connecting his calendar to 315,000 employees on the floor?
Well, the 10 hours of study allows Hazen to identify leading indicators like that massive OBBA revenue drop we talked about months or even years before they hit the front lines. By anticipating those shifts early, he forces the corporate functional teams to build the standardized solutions, test them out, and deploy them systematically.
Ah, I see.
Yeah, it prevents the local hospitals from having to invent their own panic responses when the crisis actually hits. His personal study time sets the operational tempo for the entire executive chain.
That makes a lot of sense. And that level of anticipation, it explains a strategic paradox that really stood out in their 2026 playbooks for me.
Which one?
Well, if Hazen has spent his study time realizing the system is facing a $900 million financial headwind, it seems completely counterintuitive that they are currently spending $7 billion on physical capital projects. Why spend so much when you're facing a massive loss?
Right, it seems crazy at first glance. But that $7 billion is funding what they call the ambulatory shift. And it is essential for their long-term survival. HCA is executing a massive physical transformation of their network.
Expanding out from the main hospital.
Exactly. They're expanding from an average of 14 outpatient sites per hospital to 20 per hospital by 2030. They are aggressively targeting a 30% market share with freestanding ERs, urgent care clinics, and ambulatory surgery centers.
But again, to play devil's advocate, why expand your physical footprint that drastically when your traditional insurance revenue is shrinking?
What's fascinating here is the clinical reality driving this. They refer to it as the natural lift in acuity. The patients who actually require admission inside the traditional four-walled hospital today are increasingly older, and they are suffering from much more complex critical conditions.
So wait, the hospital itself is basically becoming one giant intensive care unit.
Precisely. HCA has to decompress those main hospitals by moving routine care, minor surgeries, and lower-level emergencies to those outpatient centers. They reserve the highly expensive, resource-intensive inpatient beds strictly for the sickest populations. It is a pure network optimization strategy.
Okay, that makes sense. But if the physical hospital is now packed entirely with critically ill, complex patients, a human doctor's cognitive load hits a breaking point.
Oh, without a doubt.
So how does the system prevent its clinical staff from just buckling under that sheer complexity?
They turn to their digital transformation. And this is a crucial point, HCA instituted a non-negotiable prerequisite rule before they deploy any advanced technology. They require what they call operational quiet.
Operational quiet. I love that term. It makes me think of like trying to build a high-speed bullet train. You can't just drop a state-of-the-art AI bullet train onto crooked 19th century wooden data tracks. You have to lay down unified steel tracks first.
That is a perfect analogy. You absolutely have to eliminate the data friction first. So before scaling their AI initiatives, HCA is transitioning all of their hospitals to a unified, cloud-based electronic health record system called Meditech Expanse. They clean and standardize the data environment first.
Right.
And then, once they achieve that quiet, they deploy their three-tiered AI agenda, which focuses heavily on agentic AI.
And here's where it gets really interesting, because when you say agentic AI, meaning AI that doesn't just act like a digital filing cabinet, passively holding patient records, it actually operates as an agent to manage workflows and suggest actions.
Yes, and tier one of this agenda is entirely administrative. They use large language models, or LLMs, to summarize massive patient charts for peer-to-peer payer consults. And they deploy machine learning to analyze claims data to proactively prevent insurance denials.
So it's basically a defensive measure to protect their bottom line against that OBBBA revenue drop.
Exactly. Defending the revenue makes sense as a first step. But tier two is where the operational mechanics get really sophisticated. The standout here is a platform called Tempany. Tempany uses machine learning to predict patient demand and hospital census levels 28 days into the future.
Wait, 28 days? It can predict hospital capacity a month out.
A full month out. And it does much more than just look at historical hospital data. To predict demand that far out, Tempany analyzes community health patterns, local flu trends, and broader demographic shifts. But the true value, really, is how it applies that prediction.
What do you mean?
It actively matches the specific clinical competencies of the nursing staff to the unique risk profiles of the incoming patients.
Oh, wow. So if the system anticipates, let's say, a surge in high-risk cardiac patients in a specific region, Tempany ensures that the nurses with the deepest cardiac competencies are scheduled for those exact shifts, rather than just filling slots with whoever happens to be available.
Exactly. And the efficiency gains are very tangible. In 2025, Tempany directly contributed to a 2% reduction in length of stay across the piloted hospital.
2% might not sound like a lot to someone outside the industry, but
it's huge. When you are managing millions of patient encounters, safely reducing the time a patient needs to stay in a hospital bed by 2% is a monumental operational victory.
It is massive. But I know Tier 3 is the clinical application, and the metrics here in the source material are just fascinating. They were utilizing ambient scribing and a nurse handoff app.
Yes, the ambient listening tech.
Right. Partnering with Commurer and Google Cloud, they implemented this ambient listening technology, which is essentially AI that listens to the natural conversation between a doctor and a patient and automatically writes the clinical note in the background. The accuracy metric they track for this is the F1 score, and they're hitting 0.8 to 0.9.
We should probably define that for clarity for everyone listening. The F1 score is a metric used to evaluate machine learning models. It measures the balance between precision, meaning the AI isn't hallucinating or inventing things that weren't said, and recall, meaning the AI isn't missing crucial details. A perfect score is 1.0.
Right, so hitting an F1 score of 0.8 to 0.9 on messy, unstructured human medical dialogue is incredibly high.
It really is.
And the real-world impact is pretty clear. At Medical City Dallas, the rate of timely note completion jumped from 69% to 87%. Physicians are reporting that they are saving 2 to 3 hours of documentation time every single day.
Which is life-changing for a doctor.
Absolutely. But I do have to raise a major concern here. Letting an AI actively synthesize and write clinical notes sounds incredibly risky.
Oh, sure.
What if the AI hallucinates? What if it invents a symptom? Or worse, misinterprets a dosage amount? I mean, in medicine, an AI hallucination isn't just a software glitch. It is a potential malpractice suit or a direct threat to patient safety.
Yeah, and that risk is the absolute core of the debate around healthcare AI right now. And HCA is acutely aware of it. That is why they enforce a strict human-in-the-loop requirement. The AI does not finalize any medical record, period.
Okay, good.
A licensed clinician must review, verify, and formally approve every single AI-generated note before it becomes part of the patient's permanent file. The technology lifts the cognitive burden of typing and formatting, but the human clinician retains absolute authority and liability.
And to make sure these tools actually function safely in a chaotic ER, they don't just buy software and force the staff to figure it out on the fly. They rely on innovation hubs like UCF Lake Nona Hospital in Orlando to test the technology using human-centered design.
Yes, the development of their nurse handoff app is a prime example of this approach. During a shift change, a nurse typically spends 40 minutes manually gathering data from various systems just to hand off a patient to the next nurse.
40 minutes. That is 40 minutes away from the bedside, just collating information.
Exactly. So this new app uses generative AI to synthesize the patient's record instantly. It boasts an 86% factual accuracy rate and a 90% helpfulness rating among the staff.
That's incredible.
And the reason the adoption has been so successful is the development process. It wasn't coded by, isolated software tech bros guessing what a nurse needs.
Right.
The playbooks explicitly state it was built by nurses, for nurses. A dedicated team of 21 nurses across 4 different hospitals actively guided the iterative development, ensuring the interface highlighted the exact clinical data they actually used during a real handoff.
But, all of this cloud architecture, the ambient scribing, the agentic AI, it is entirely useless without the right humans to oversee it, correct it, and physically deliver the care.
Absolutely. Technology is merely the tool. The talent utilizing that tool is the actual moat protecting the business.
And we know the industry is facing chronic nationwide labor shortages right now. HCA's strategy to combat this is called underground talent. Instead of just fighting to hire external candidates in a depleted market, they are pouring capital into the people already walking their halls.
Yeah, they are heavily investing in career changer programs and tuition assistance. They're spending $40 million on tuition support in 2025 alone.
And that $40 million investment isn't just a recruiting perk, it is a deeply embedded cultural strategy. The ultimate proof of concept for their internal talent pipeline is CEO Sam Hazen himself.
Right.
44 years ago, he utilized HCA's tuition reimbursement program to advance his own education, rising from literally an entry-level position all the way to chief executive officer.
When the CEO is a product of the company's own tuition assistance program, it proves to the workforce that the system genuinely invests in its own people. That's a powerful message.
So what does this all mean for the organization as a whole? Let's recap. We have a $900 million legislative storm. We have physical network optimization, the pursuit of operational quiet, the deployment of agentic AI, and the cultivation of underground talent.
It's a lot of moving parts.
It is a lot. But how is the leadership actually held accountable to execute all of this without letting patient care slip through the cracks while they're just chasing financial targets?
Well, that accountability is structured through the 2026 Executive Performance Excellence Program. Executive compensation is tightly governed to balance these competing priorities. So 80% of an executive's cash award is tied directly to financial EBITDA targets.
And let's just define EBITDA quickly for you listening. That stands for earnings before interest, taxes, depreciation, and amortization. It is essentially the purest measure of a hospital's day-to-day operational cash flow and profitability.
Exactly. So by tying 80% of compensation to EBITDA, the board ensures the executives are aggressively managing the financial headwinds caused by the OBBA. But the remaining 20% of their compensation is strictly tied to clinical quality metrics like patient care experience, complication rates, and sepsis reduction.
But, if I am a hospital executive facing a massive financial shortfall, I might be heavily tempted to just cut corners on staffing or patient care to make sure I hit my EBITDA numbers and secure that 80% bonus, right?
Oh, the board anticipated that exact behavioral risk. And to prevent executives from sacrificing care for cash, they instituted what's called the clawback provision.
How does that work?
If an executive fails to hit at least 90% of their financial targets, they receive 0 quality-based payouts, regardless of how well the hospital performed clinically.
Oh, wow. So clinical excellence and financial viability are legally and financially linked.
They are inextricably bound together. If we connect this to the bigger picture, if quality drops, their total compensation takes a severe hit. You cannot sacrifice the clinical mission to save the financial ledger, and you cannot ignore the finances while trying to deliver care.
Right.
And this strict governance model is a major reason why HCA has maintained a 16-year streak as one of the world's most ethical companies. They utilize that reputation for consistency and ethical governance as a strategic differentiator in an otherwise chaotic market.
Pulling all of these threads together, the narrative through line of their strategy is incredibly cohesive. To survive the OBBA's $900 million storm, HCA isn't just bracing for impact. They aren't waiting for a tech startup to disrupt them.
Nope.
They are using their sheer scale to enforce operational quiet. They are deploying agentic AI to predict patient demand 28 days out and to alleviate the crush of clinical paperwork. And they're building a physical and human network capable of managing the most critically ill patients. For you listening, whether you are leading a massive corporate division, prepping for your own strategic planning session, or simply trying to navigate a period of intense flux in your own industry, the core lesson from HCA's playbook is profound. True disruption has to be an inside job. You have to own your internal realities, map out your inefficiencies, and organize your data before market forces or government legislation mandate those realities for you.
It really is a masterclass in institutional resilience.
Yeah.
But, looking at the trajectory of these specific AI tools, this raises an important question that goes beyond corporate strategy and touches on the very philosophy of the medical profession itself.
Oh, I'm intrigued. Where does this lead?
Well, think about it. If agentic AI eventually achieves its ultimate goal, if it stops merely recording data and actively begins suggesting clinical improvements, predicting 28-day demand trends with perfect accuracy, and, autonomously coordinating care activities in the background, how does that fundamentally shift the core identity of a doctor or a nurse in the hospital of the future? Will the ultimate value of a medical professional be less about being a memorizer of facts and a doer of manual tasks, and much more about acting as a high-level editor and moral director of artificial agents?
An editor and moral director. That completely redefines what it means to practice medicine. Instead of a clinician just trying to keep their head above water while manually charting every symptom, the human becomes the ultimate strategic navigator. They provide the empathy and the ethical oversight, while the AI runs the engine room.
Exactly.
Thank you so much for joining us on this deep dive. We hope this exploration of self-disruption, legislative strategy, and the future of healthcare gave you some powerful new frameworks for your own strategic thinking. We are going to leave you with that lingering question to mull over. In your own field, as technology advances, are you preparing to just be a doer of tasks, or are you ready to become the moral director of the tools you use? Take care, and we will catch you on the next one.